Hello, and welcome to Talking About DM to Children, Family Members, and Doctors. This session is part of the Caregivers and Self-Care track, and it's intended for caregivers of individuals living with all forms of DM, as well as individuals living with DM themselves. The session is being recorded and will be available for viewing after the conference on the MDF Digital Academy at www.myotonic.org/digital-academy. I am Mike Knoppen, the MDF Program Director. To ask our presenters questions or to make a comment, please use the chat. The panel will answer questions and respond to comments at the end of their presentation. We have a wonderful panel today, including physician, social worker, nurse, and an individual living with DM herself. I'm delighted now to present that panel to you. First, Dr. Sheetal Shroff, who specializes in neuromuscular diseases and electrodiagnostic medicine. She's co-director of Myotonic Muscle Multidisciplinary Clinic at Houston Methodist Hospital. Her research focuses on clinical trials of investigational new drugs for the treatment of muscular dystrophies, amyotrophic lateral sclerosis, commonly known as ALS, myasthenia gravis, and chronic inflammatory demyelinating polyneuropathy. Forgive me. She's also interested in utilizing neuromuscular ultrasound in clinical and research areas. Also with us today is Reagan Shivitz, nurse coordinator in the Neuromuscular and Myotonic Dystrophy Clinic at Houston Methodist Texas Medical Center, who earned her bachelor's degree in nursing from the University of Arkansas. Rebecca Axline is a clinical social worker at Houston Methodist with expertise in advanced care planning, caregiving, cognitive therapy, mindfulness, and trauma-focused care. She holds a BS in sociology, a Master of Science in Social Work, and an advanced palliative hospice certification. Last but not least, Cindy Voteman has DM1 and is a patient of the Houston Methodist DM Clinic. With that, I would like to introduce again Dr. Sheetal Shroff, who will begin our presentation today. Dr. Shroff.
Thank you, Mike. Yeah, thank you for the introduction and giving us the opportunity to present at the MDF annual conference. Let me share my screen. Okay, here we go. Okay, so myotonic dystrophy, as you all know, is a multisystem genetic disorder which affects not only the muscle, but then it can cause fatigue and cognitive issues with eye involvement with cataracts and droopy eyes, cardiac abnormalities, GI system involvement, endocrine with thyroid and diabetes, immune system, peripheral neuropathy, weakness in distal and proximal muscles, and then myotonia, myalgia, that's the muscle pain, respiratory muscle weakness, facial muscle weakness including. So this condition is inherited as an autosomal dominant, meaning there is a 50% chance that a child can inherit from the affected parents. DM1, the type 1 is the most common form of muscular dystrophy in adults. It can occur in 1 in 8,000 of muscular dystrophy, 1 in 8,000 population. Now, there are two types of myotonic dystrophy, type 1 and type 2. And type 1, it's because of, it's called as a trinucleotide repeat disease. That means there are these CTG repeats, which there are too many of these repeats in the gene, and then that causes all the symptoms of the myotonic dystrophy type 1, like myotonia, distal weakness, cardiac, GI, endocrine, and cognitive involvement. There is also a congenital form where babies are born with severe weakness. It can affect their feeding, it can affect the breathing, and they require intensive care monitoring. And at times it can be fatal also. And we have type 2. This is caused by, again, another repeat, but this is a 4 repeat CCTG. And when the repeats go beyond 75, that's when the disease manifestation can happen. Here, it's a little different than type 1. In type 1, it's more of a distal weakness, but in type 2, it's more of proximal weakness, meaning if it's in type 1, if it's more of like hand and foot weakness or calf weakness, in type 2, it's more of thigh and upper arm weakness, but they still have myotonia, muscle pain, but there is lesser degree of systemic involvement, meaning the other systems. It's seen only in adults, but it's much rare compared. It's much rare compared to the type 1 myotonic dystrophy. Whenever I see a patient in a new patient in the clinic, their first question, or almost always, will be, do you know DM? Have you seen patients with DM? And when I say yes, it's almost like a huge relief, or like a weight is lifted off their shoulder. So that's kind of the impression, I get, and they do express the same feeling. The reason because we have a multidisciplinary team here at Houston Methodist, where it comprises of neurologists who are neuromuscular specialists. We have cardiologists, pulmonologists, physical therapists, occupational therapists, speech nutritionists, who have all seen and taken care and managed myotonic dystrophy patients. So yes, I can say yes, I have seen and know about myotonic dystrophy, but then it might not be the same with a community neurologist who might not be a neuromuscular specialist, and they might not have had experience with myotonic dystrophy patients. Same goes with other therapists and cardiologists. So in those instances, it becomes challenging for both patients and physicians to kind of navigate through that process of okay, what needs to be done, or who should I see? And that's where, communication is key. And also educating yourself as well as even the physicians is important, because not everybody knows about myotonic dystrophy. And there are really good resources, especially with Myotonic Dystrophy Foundation. They have a lot of guidelines and resources, not just for even for neurologists. They have for pulmonologists, cardiologists, respiratory, physical therapists, occupational therapists, and pretty much for all the specialty anesthesiologists. So there are a lot of guidelines available out there. And that's really important to convey to your doctor, or whether it be neurologist or be family physician, to kind of communicate that and let them know that there are resources available. Now, next is, you are your advocate. A lot of patients say okay, who should I see? What should I tell my doctors? So since we know it is a multi-system disease, that means we need multiple specialists to manage myotonic dystrophy patient. So it comprises of neurologists, cardiologists, pulmonologists, ophthalmologist, primary care physician, endocrinologist, and gastroenterologist, based on the symptoms. If you do have thyroid or diabetic issue, then we might need endocrinologist. But sometimes, most often, primary care physician or a family physician is able to manage those. Gastroenterologist, if one is having a lot of GI motility issues and gallbladder issue, then we might need a gastroenterologist on board. So the other thing is what to ask, if it's say a patient is seeing just a primary care physician, what to ask them, so they'll need referral to see all these specialists. And then also when and how frequently should I see these specialists? So typically, this is just a rough estimate. Neurologists, I would say every 6 months, if not at least every 6 months, if not more frequently. Cardiologists, again, every 6 to 12 months. But if a patient has underlying cardiac issue, then that becomes more frequent, more like every 3 to 4 months. Pulmonologist, the same goes here. If there is underlying or having any respiratory issues, then it might become more frequent than 6 months. Ophthalmologist, at least annually. And then primary care physician, at least every 6 months. And then endocrine, gastro, and genetic counselor as and when their services are required. Now, the next thing my patients sometimes ask is, I have so many symptoms going on. I don't know what to say. I don't know what not to say. Like, who should I tell these symptoms to? So that's one of the questions, like which comes up. Usually what I say is like, you just tell me all your symptoms, 1, 2, 3, 4, 5, 6, how many ever you have. And if it is within my expertise, then definitely I can help. If it is not, then at least I can guide you or refer you to the appropriate specialist. So me as a neurologist, I want to know, like, is there worsening weakness? Because that'll help us assess for like, okay, do you need any equipment or a rollator or a power chair and lifts and those kind of things. For those equipments, it's really helpful. Gait issues, like if one needs a brace or ankle foot orthosis, you do AFOs. Breathing, even though I'm not a pulmonologist, I don't specialize in managing breathing issues. It gives us a starting like getting PFTs or initiating a sleep study, and also referring to the appropriate or the right pulmonologist who knows how to manage myotonic dystrophy patients. Swallowing issue, is the patient safely swallowing, or are they choking or aspirating? Do we need speech therapist assessment, or do we need thickeners or diet modification? Or has it gotten to a point where a patient is losing weight and choking that they need a peg tube? And also abnormal weight loss, is that an issue, not able to put on weight or maintain weight? Then we might need nutritionist and dietitian assessment for supplement and guidance. And also fatigue. I know fatigue is a big, huge symptom, or one of the component of the myotonic dystrophy. There are medications to improve fatigue, but again, we have to be cautious, especially in patients who have underlying cardiac issue, in using these medications, or it has to be done under close cardiology guidance, using these medications. But there are medications if fatigue is a big issue, to help combat that. Next, with a cardiologist, symptoms like, are you having lightheadedness, palpitations, chest pain, getting EKG and echo? One might not do a cardiac MRI like every single visit, but that's I would defer that to the cardiologist, whether they would want an MRI or not. And sometimes Holter monitoring. That means the cardiac rhythm has to be monitored for a long period of time. So maybe at times for 48, 72 hours, or sometimes maybe for a month. And the next question is, do I need a pacemaker? So that's an important question, because that's the next question after Holter monitoring is there rhythm disturbance, or is there some irregular heart rate, and that warrants a pacemaker placement. These are some of the things to tell your cardiologist. For pulmonologist, anything related to breathing, shortness of breath, or worsening shortness of breath on exertion, even if it is minimal exertion, inability to speak full sentences in one breath, where patients will have to stop, speak a few words, stop, take a breath, and then speak a few words. So that's like, inability to speak like full sentences, and disturbed sleep at nighttime. And this can be indication of what is known as hypoventilation. That means the body is not getting enough oxygen, or enough, or there is no good ventilation happening at nighttime when we sleep. And these patients can present with like daily morning headaches, increased fatigue, and increased daytime somnolence. And sometimes family members do say like, oh, they stop breathing for like few seconds at nighttime. You know, we call that as apnea. So these are all the symptoms or to look for, or also to discuss with the pulmonologist. Usually we want to get pulmonary function test, that is the breathing test, to check how strong your breathing muscles are every 6 months. But again, it depends. If there is underlying respiratory issue, then your pulmonologist might say get it more frequently. And assessing the need for breathing machine. There are a lot of BiPAP, AVAPs. There's a lot of different breathing machine available to help assist with the breathing, especially when we sleep. And also secretion clearance. If in some patients there is weakness of not only the breathing muscles, but also like throat and diaphragm. So this can cause weak cough. And if one cannot cough, that means we can't clear our secretions out. So then that leads to like, okay, do they need cough assist device to kind of help clear secretions? So these are all the issues with the breathing muscles. Now, next, the lung tissue itself, we want to keep that also healthy. Meaning breathing can fail not only from breathing muscle, but even if lung tissue is affected. So what are the things which can affect the lung tissue? Infections like flu, pneumonia, COVID, or it could be even aspiration. That means, you know, just choking or like on food and then developing aspiration pneumonia. So all of this can affect the breathing. So preventive measures like taking flu vaccines, pneumonia vaccine, COVID vaccine, all this is important in preventing further damage of the lungs. Ophthalmologist evaluation at least annually for cataract, and also at times droopy eyes that can impair vision. There are certain special like frames which are available to help with the droopy eyes, and some patients have undergone even surgery, but it's not a guarantee that surgery is going to help. It can be only like temporary, and later on, again, the eyelids might droop. And primary care physician evaluation for thyroid and diabetes annually, regular cancer screening based on the age of the patient. And when required, genetic counselor or even like obstetrician who knows how to manage patients with myotonic dystrophy. It's very important to discuss about family planning, especially in younger patients. And also genetic counselor might also help in how to discuss with children who might not be severely affected, but they do have the disease. And also discussing about anticipation. That means the severity of the disease increases every generation. Like grandmother might not have any symptoms at all. Mom might have little bit of symptoms in the hand, and then now the daughter has severe symptoms. So every generation there is worsening, or the severity of the disease increases. And also for patients who do want to have biological children, there are in vitro fertilization option, and that's where the obstetrician really comes into play. And if one is already pregnant, then what are all the things they can do to find out if the baby is affected, like in the prenatal workup. So these are all the things which to kind of keep in mind, and then, you know, to ask your physician. So in regards to physical therapist, there's an exercise guide regarding stretching, range of motion exercises, balance training, brisk walking. So it's key to know what are the type of exercises you can do, because exercise can, if done in a wrong way can harm you, but if done rightly, it'll greatly help. So it's important to know what are the type of exercises you need to do. And again, occupational therapist to assess for any equipment based on the weakness or the group of muscles involved, nutritionist for protein supplement, managing swallowing issue or weight loss management. Also, there is this this one is off of the Myotonic Dystrophy Foundation website. This choosemyplate.gov. It's a really cool website where you can, based on your height and weight, it gives what are all the things you need to have in your diet to kind of make it well balanced. So it's a great tool, and it's very easy to kind of follow. It has like individual fruits and individual grains and food itself. So it's really good. Speech therapists, especially in children who have speech and language problem, they play a key role. And these are all the specialists you will need to and kind of talk to them about each individual needs. So next, this is another question which our patients say, like, are all my physicians communicating with each other? My cardiologist with my neurologist, or my pulmonologist with my primary care doctor, and how do I make sure that everybody is communicating? So one thing, it's easy when we have a multidisciplinary team, because like then we are all there at the same time or in the same institution, and we can all see each other's assessment and stuff. So it really becomes a bit of a challenge when it's not a multidisciplinary team and it's like out in the community. So then I would say either your primary care doctor or your neurologist, would be the key person to get all the information, or make sure that they get all the information from other specialists and help you navigate through the process. So that would be the two physicians, I would say, like your primary care and your neurologist, who will need to know what's going on, what's the recommendation the cardiologist has given and the pulmonologist has given. So next is the insurance question. I know Rebecca will be covering some of this, and I know Reagan will be covering some of this. So the insurance, does not cover physical therapy visits. There's only so many limits, 12 visits, and that's it. After that, insurance does not cover. Yes, we do face this commonly sometimes, like we do try to appeal them, but most of the times, insurance, they uphold their denial. One important thing is to check with your insurance which physical therapy place is covered through your insurance, to make sure that you get the most out of it. And also, like, to kind of have an exercise regimen for yourself. And there's a really good again, on myotonic.org, there's a really good it's like a toolkit, or like a PDF to kind of come up with your own like exercise regimen, and to have a support group to motivate each other, so that you can continue with some of those therapies, exercises yourself. So these are some of the things which I tell my patients, like, yes, physical therapy visits, we're gonna run out of it, but then like, have a regimen and have a support group and motivate each other. And the big question, what should I say to my family? So it is ideal to discuss with your family, because they are your immediate support, and help them understand your problem. Like, you may be sleepy, like you sleep more than normal. That's part of myotonic dystrophy. It's that's the way it is. Fatigue is a big component. And not every day is the same. Like one day you may be more active and you might participate in things, and the next day it may be the opposite. And you do have muscle weakness, and you might need to take more naps, or you sleep longer. And some patients have even said, like, people at work have commented, like, why do you look sleepy all the time? Because they have droopy eyes. So these are some of the things, like, which it's better to communicate and let them know that this condition can present with all these symptoms, and it's not you doing it, it's just that's the way it is. And also it's important to discuss with the family, just so that if there are other affected members in the family, then they can get appropriate specialists and care. And the next thing is, just because one does not show any symptoms doesn't mean that they have the disease. Um, they might be still, they might have very mild symptoms, or they might not have anything clinically, but still they still have the disease. So it's all of these things, becomes important to kind of discuss, with the family. Again, ultimately it's you, your body, and you reveal as much information as you want them to know. Um, but these are some things which I discuss, with my patients. And that kind of gets to the conclusion of my talk. And I'm gonna let Reagan, our nurse, take over. And she's gonna talk about some of the other nursing questions which we get most commonly.
Hello, everyone. I'm excited to join you guys. And I'm going to share my screen here real quick. Just give me a second. All right, so this PowerPoint will have Rebecca and I am the nurse here at the Myotonic Clinic, and Dr. Schroff has asked Rebecca and I to give you guys a nursing background and a social work background. And I've been here with the clinic for 2 years, but I also worked inpatient for a little bit as well. And I also work in the same disease processes as Dr. Schroff in the neuromuscular group. So I will touch on some of the same things she did. They did let us know we could put a quote in. So I went ahead and put "Be curious, not judgmental" by Walt Whitman. So you can kind of see that sometimes people can pass judgment if they're unfamiliar with myotonic or other disease processes. So it's good to get out there, talk about the disease, get in the support groups, ask questions. That's why all of us are here today. So I'm going to go into the nursing portion and maybe think about during my presentation if you have access to a nurse, or if you've talked to a nurse before, what you think the nurse could help you with. And I'm going to try and go over that. You may not have a nurse in the community, but hopefully Rebecca and I can give you some resources and how to get those resources without having a nurse or social worker on your particular team. So the first question would be, I'm struggling communicating my needs to immediate family, and that seems to be a common question for a lot of you. From my perspective, I would say that it's best for you to understand the disease process, and that's why we're here, so you can get to know more about it and know how to present what you want out of your care. So as Dr. Schroff mentioned, the disease progression presents at different stages. Your symptoms may be less severe in the beginning and get worse over time, or depending on the type of myotonic dystrophy you may have some of those more severe symptoms from the start. But you want to know what stage you're at and how you can help family members know where it may go, and better be prepared in that aspect to know what to expect, and communicate those needs to them as well. And you also want to be aware of what family member or what work member or what friend you want involved in your care. It doesn't necessarily mean you're going to want everybody to know everything about you or what you're always going through, but you kind of have to determine for yourself as a patient what role you want each person to play in your disease progression. Of course, I know there's a lot of parents too trying to help figure that out for their children, and that's an important question to ask yourself, in what role do you want each person involved in your care to know as well. Directing family to the appropriate resources or friends, whoever you want to know more about the disease process. I, and everyone's a different learner, like to see the videos, the pictures, the educational resources. The Myotonic Foundation has a ton of information that's really good on their website. There's a lot of other resources out there too, to help y'all understand. Instead, sometimes we have patients Googling information and trying to find the answers on non-reliable resources, and we want y'all to have the best, most up-to-date information as well. So that's important. Also, knowing when your symptom onset started, because you may be a family member who may not have known you had a family history, may not have known how to figure out what was going on. You just knew you had symptoms starting at this point. So maybe your PCP referred you over to a neurologist, and or your child had symptoms starting at a young age, and you may not have known the genetic predisposition with myotonic. And like Dr. Schroff said, it can get more severe as time goes on through generations. So it's good to have a family history and also be aware of symptom onset and when new symptoms occur. And also one important factor is in these support groups and meeting other patients with myotonic, you may not present with the same symptoms as everyone, or you may not present with the same degree of severity as well. Breaking it further down on myotonic, I try and break it down as simple as we can, because a lot of times some physicians and nurses and people in healthcare can talk in medical jargon. And so trying to break down some of these terms to better understand them, people may understand better. And so as you all know what your symptoms are, you can also present them, well, this is actually the name of the disease process, myotonia, inability to relax your muscles. A lot of times patients present with not being able to make grips or things like that, weakness, muscle degeneration. Dr. Schroff talked about a lot of the symptoms with the different systems. This is a further breakdown as well, and it's a good way in bullet format to see the 3 different types. The congenital form, which a lot of times it's cognitive disabilities start within this form, the respiratory issues as well, difficult swallowing, clubbed feet, facial and muscle weakness. And so to be aware with each type, what traits or symptoms typically follow. And there can be variants here as well. Of course, DM1, muscle weakness, respiratory weakness, facial weakness, difficult talking, thigh weakness in later stages, the myotonia we just talked about, heart abnormalities, and sometimes facial changes, long face. For DM2, it's usually upper leg weakness and early onset, but a lot of similar difficulties, but tend to be less severe and less of a cognitive effect as well. But like I said, these can vary. It's just good to know the different types as well, in case you're presenting to a physician who isn't as familiar with all of the different types out there as well. Back to how to explain it to younger kids and people in the community. Visually for children, explaining to them what may or may not occur down the line. glasses, they may have cataracts, breathing difficulties, explaining that to them. It may be less scary if they see a picture or a video or meet somebody. And I know that's hard during this time, to get out in the public to meet more, but people with the disability. But knowing that there is ways to explain this to kids and family so that you can educate them and friends too, about what's to come with the disease process. Cardiac issues. The bottom right picture, this is an AFO, difficult walking, things like that. So I think that's a good way to try and explain it, and talk about it. And being open is good with your children, about where they're at, and also giving them open communication as well so that they can talk to you about their concerns also. My role, and what I can do from a clinical standpoint to help myotonic patients, communication. I know Dr. Schroff stressed that in all of her slides as well, but communication is huge. And we're excited to see y'all's questions as well, because we want to hear from you guys also. Advocating, that's a big deal for nurses to advocate for our patients. And we want to be kind of the in-between, if you have access to us, to help in some of those times. Maybe you are scheduled for a surgery, and a big part is concerns with risks of surgery, weighing the benefits and the risks there, and making sure with your physicians that that's the right decision. We provide all of our patients prior to surgery a clearance letter that's very specified to Myotonic. We specify anesthetic management, and that's actually on myotonic.org. There's a resource there. So even if your physicians aren't familiar with that, that's something you can print and give to your doctor that they can provide if you're planning on having a surgery, or you can even provide it to your anesthesiologist when that comes up, because I know there are a lot of surgeries that may help your disease process, but you're afraid because of the sedatives that can also cause worsening to your neuromuscular condition. We also tell patients to get involved with their pulmonologist during this time, because we want to make sure your respiratory status is okay to undergo surgery. So that's just an example of us advocating, and you being able to advocate for yourself in certain situations like that. Also, that goes into, again, the coordinating with different team members. If you don't, or I would say probably starting with a primary care physician is the first step, because they are the first resource to be able to get you to those specialists. The specialists are sometimes hard to get into if you haven't established care. And then, of course, having your neurologist, your pulmonologist, your GI doctor, cardiologist, depending on your symptoms. But it's always good to have those doctors, even if you're just seeing them annually as checkups, in the case that symptoms progress and your disease process progresses over time. So you're not scrambling, because sometimes it can take a long time to get into these physicians. Within our clinic, we do try to bring in speech therapists, like Dr. Schroff said, physical therapist, occupational therapist, and social work. With the speech, it's definitely with the swallowing. We want to make sure that, if disease progresses and there's a need for swallowing devices, aids in diet, things like that, that you have that available. With physical therapy and occupational therapy, they're a good resource to nursing teams, because they help us get you all approved for a lot of those DME equipments by telling us what is needed, because they're the ones assessing what you can and can't do. And they're presenting their notes to insurance as well. And so is the physician. So again, the nurses, we try to be resourceful in getting you guys enough resources. We want you to have all of the information we can help with, as well as the physicians. And one thing we notice within our clinic is follow-up. We really want patients to maintain follow-up. We know how hard it is to get in and out of the doctor's office. But knowing that if disease process does progress, or if you do have to have a hospitalization, you have someone to call, you have someone to reach out to who knows something about you, because you have followed up with the clinic at least every 6 months to every year, and we know where your disease progression is at, in the case that, you know, you needed a hospitalization or anything like that. So we are advocating for our patients to maintain compliance and coming to those appointments and being more excited and more open to continue to see their physicians, even if your physician isn't that familiar with myotonic, you can also teach them things too. So advocating for yourself in that aspect is good. And also, if you have family members involved or things like that, they can help keep you accountable on coming to these appointments. And sometimes we do allow visitors. COVID has been hard on our clinics, but having visitors come in and be an extra ear, extra eye, to intake all the information that the physicians are sharing at one time. It can be overwhelming in one appointment, and you can't learn everything in one appointment about this disease process. It's just, it's broad. So on to a different topic, which is the genetic testing portion, which I also help coordinate here in our clinic. This is a lot of patients are asking, how do I get genetically tested? Is it affordable? Can I, you know, go out and do this on my own? So one thing is to know, we do see it's not always the most affordable thing. And so the most important thing to try and get that covered is, one, to have your doctor established, them to have a medical history on you, have a family history. If you don't have that, it's always good to have a family history, to know some sort of backdrop when we present these to the genetic testing companies. We want to have as much information, all your testing you've had done, imaging, if you've had any procedures, EMGs, things like that, to help get you to this diagnosis. And you want a firm affirmation that you do have myotonic. It's a good way to have that. And it's also can be a peace of mind, that your symptoms you've been struggling with, to have a confirmed diagnosis. And there are also genetic counselors with these companies, and they will give more information than I can even give probably in this 1 hour talk. But there are available resources. They're not always the most affordable. What I would research first is which companies are in network with your insurance. I've listed a few on this PowerPoint: Athena, Mayo Clinic, ARUP, Washington University, MNG Labs, and Baylor Genetics. Some of these are more pricey if they're private, if they're outside of labs and things like that. But there are new genetic information coming out every, quite constantly. There's new companies coming out. We just started at Methodist our own genetic resource where they will actually do the genetic counseling for us if we send the referral. So that's a good process. And once you get testing, you're going to have a lot of questions, and these genetic counselors are very versed in that. So we like to start the process and give you the background information, send in all the clinical information, try to do everything we can to get these approved. They do require benefits investigations through your insurance, but they can be somewhat, a couple $100 to a couple $1,000. They can fluctuate. Prices can change over time as well. But, it's kind of up to you as what cost it is to know your disease process, and know for your children and for future generations, to be aware of their genetic history as well. Most of these tests are pretty easy. They can be done through blood, a buccal swab, or just even a saliva sample. And some of these places send kits to your house and things like that. Those tend to be more affordable than the private labs that or the universities that do their own testing. Those can be more expensive, but they tend to have more resources as well. So that's a broad outline. And we do tend to see that commercial insurances do better in coverage, at least from my experience. Now, financial assistance options, each company has their own financial assistance options. Some do self-pay cost. If you don't go through insurance, that could be a discount. And some of them have financial assistance programs that you can apply to. And if they offer that and you determine to do testing, always agree to that up front, because it would be way harder to go back and get that. So if they do offer that, I would say to go ahead from that. So I know that's a lot of information, and I'm happy to talk to you guys and answer questions towards the end regarding nursing. But the main thing I want you all to know is that you can advocate for yourself if you don't have a resource of a nurse with you all the time, and continue to communicate as well. And I will pass it on to Rebecca, our social worker, and she will, I'll do her slides, but she will talk to you a little bit about her role.
Great. Can you guys hear me? I think you can, Reagan, right? Okay. So hi, I'm the social worker, Rebecca Axline. Thank you so much for having me here today. And I'm going to talk real quickly because I want you all to hear from Cindy, who's going to be a phenomenal part of today's panel. So there's a lot of questions for social work. And one of the things I need to say from the beginning is we have a wide, broad audience we're talking to from all over the country, from all over different places. And as you may or may not know, there are private insurances that many of us have if we work in, if we work or our spouses work or someone on our family we're covered under. There's also federal coverages through Medicare if we're on disability or we're over the age of 65. Or there's Medicaid. Medicaid is a federal program, but it is run by the state. So I may be talking here in Texas where we have to have a certain amount of money to be on Medicaid, and in California, New York, other places may have a whole different criteria for being on Medicaid. So it's important that you gather information. And if I can tell you one thing to do, it would be start gathering information. Even if you're working full time, even if you've got total coverage from a private insurance and it's a great insurance and everything's great, because decisions are hard enough to make, but when you make them in crisis, they become so overwhelming. So know the information and the things that you might have at your disposal. I'm fortunate enough to be an outpatient social worker, strictly outpatient with all the neurologists. But in many institutions, the only social workers are on the inpatient level. So you may need to explore other options in your community, area agency on aging. If your child is involved in a pediatric hospital, there may be social workers there. See who can be available to you to help you navigate and have this information. It's really important. Also, the question here about advocating in the workplace. The American with Disabilities Act indicates that your place of work should accommodate your ability to work. Now, it doesn't have to create a brand new job just for you, but they should create accommodations. So if you have some difficulty, mobility issues or getting to the restroom or visual issues, they should make reasonable accommodations. And it's really important to know your advocacy. Our state has an agency that works disability advocates, but every state might have different organizations, but scout out what those organizations are. If it's important that you go and talk to your human resource department, whether you're talking to them about accommodations, if you're talking to them about perhaps going on disability, maybe it's more difficult and it's fatiguing for you to stay with your employer. I think it's really good to bring someone with you, not because you want to be filing lawsuits or litigation happy, but you want a second set of eyes and ears. So it isn't he said, she said kind of information. Some people I know bring a neighbor. Some people bring a clergy person, not necessarily a lawyer, because you don't want to come with a defensive posture, but advocate for yourself and learn about what you should be getting and what you should be having in the work location. If you decide that it's too difficult for you to continue working, then I think you need to explore those options. And they can be anywhere from short-term disability or return to work issues. It can be long-term disability, can be Social Security disability if you've worked enough quarters. If you're under the age of 21, it could be Social Security, SSI, Supplemental Security Income. Again, there's a whole dictionary of definitions for all these things. So look for someone who can help you. And I'm sure you're going to have all our contact information. So even though I may not live in the state that you're in, I'm more than happy to answer a general question and point you in the right direction. So another thing is about who do I talk to about getting help? And the other speakers have already addressed that a little bit, but I think it's important to reach out and know your clinic team members. If you're in a multidisciplinary clinic, yay, then reach out to those members and find out information. If you're not, then that's when the support groups and the MD websites are so powerful, because they can connect you to people in your area and resources and ways that you can find people to support you in your home and in your journey every day. There's vocational rehabilitation counselors in every state in the union. So there's no problem. Just find out the name of the organization in your state. That can change. Find others living with MD, and I bet everyone on here is on a Facebook group or a support group of some sort, whether you're a patient living with MD or you're a loved one that takes care of them or lives with them. It's really important. Next slide, Reagan. Does insurance cover all I need? As I said before, realistically, I would love to tell you it did, but insurance companies stay in business by not paying. They're a business. It's not about you. It's not about me. They're running a business and they want to make money. So realistically, as Reagan mentioned, as Dr. Schroff mentioned, we need to validate the reasons for you getting the things that you need, whether it's in a documentation, if it's in an order, if it's in an appeal, all kinds of things that we need to do. But explore all your resources. If you're working with a private insurance, ask for a case manager. Yes, those case managers are there to save the money for the insurance company, but they also can tell us exactly what we need to provide in order to get you coverage. If you're dealing with a Medicare Advantage plan or a private insurance plan or a marketplace plan that has in-network and out-of-network options, have your social worker or someone who can advocate for you call and find out who's in network, because that's going to save you money, save you heartache, and get you the care that you need. I do that all the time, find out who's in network and then give them the information. And so does Reagan. We work as a team, and hopefully you will have a team that does that as well. Also, use your family that love you dearly. If you've got an IT expert in the family, have them figure out the ways to get you connected to all the internet and the apps and things on site. If you're involved in your local church, have those folks advocate for you and help you get the things that you need. Knowledge is power. And you're all here to learn about your disease, but also to learn about your rights and responsibilities as a person living with MD. I would encourage you also, I don't think it's been said here, but I would also encourage you to find legal advice, not because you're going to sue someone. Elder attorneys, other attorneys deal with what we call medical information and medical power of attorneys, advance directives. They also deal with financial power of attorneys. And if you have the type of MD that may eventually affect your cognitive ability, it's really important to put all those things in place before that happens. For you to get a financial power of attorney, people on your bank accounts, Social Security release of information, all those things, so that if those things if you need help in the future, those things are already in place. It will cost you a whole lot less to go to an attorney now than it will be in the future if your family has to go for guardianship or something else like that. And I think the communication about talking to family members, has been already covered, but I'm going to mention one more thing. I think it's really hard to talk about difficult conversations, whether it's about the disease I have, the possibility that I gave you the disease by being your parent, that perhaps somewhere down the road, things might get to a point where I can no longer work, or maybe we're even talking about end of life and making plans. Those are really hard conversations. And most people don't want to have them, because once you start having them, everybody gets depressed and funky and nobody knows how to get out of the conversation. So I think it's really important to frame those conversations. And if you've ever been around a pilot, you know, when they're learning to fly, they do what they call touch and go operations. They take the flight up and they touch the ground and they go back up because they're practicing how to land safely. So if you're having conversations like this, have a short, brief conversation. Let's talk for 5 minutes about what's going on with my MD. Let's talk 5 minutes about what I've decided I want to do in the future, where my paperwork's going to be. Use the neutral words, and then say, after 5 minutes, we're going to go have lunch, or we're going to go walk around the block, or we're going to do something fun. Have those conversations short and brief so that people who love you can honor your decisions and honor what you want. And you're also in the grief that all of you are dealing with. Grief is not just about death. It's about any change. You certainly know during COVID, we've dealt with a lot of grief. So it's really important to do those things. And I also, back to the educating others about your disease, I heard this from someone who had a different disease called myasthenia gravis. And they said, we made up some little business cards that just showed the websites that were really good websites for us to learn about MD. And when anybody would ask us about it, we would give them the card, because if they really cared about us, they would go to the website and they would then learn about what you could do. I also heard about the fatigue issue and how people don't always understand when I'm fatigued. It's important that you manage your emotional energy as well throughout the day. And just like the Reagan and Dr. Schroff suggested, if you're feeling physically fatigued, maybe the day before you're going to do something special, you take it easy. And the day after a picnic or something special, you take it easy. It's also important to manage your emotional energy. Well-meaning people can say stupid things. Let me say that again. Well-meaning people can say stupid things. If you're in the grocery store or you're with a family function and they go, how come your eyes droop? How come this? How come that? It's really okay if you have a script that you go to so that you don't have to get in a long, exhaustive discussion about why you're tired all the time. It's okay to say, my eyes are droopy because I have a neurological disease called myotonic dystrophy. If you want more information, I'm glad to tell you where to find that. But thank you for asking. I don't really feel like talking about it more. Now, you might want to talk about it more, but if you're exhausting, what you don't want to do is have them come back and say, well, I knew someone that did this, and maybe you should do this. And you get in this long, drawn out, emotionally fatiguing conversation. So know that you have control to manage your emotions, just like you have control to manage your physical exercise and energy. So I'm going to stop there because I think there's a lot of other questions, but I want Cindy to talk more. And if there's any questions at the end, I'd be glad to honor those. Thanks.
Thank you, Rebecca. Okay, can everybody hear me?
Yes, Cindy, we can hear you.
Okay, good. All right. Well, I am just a patient with myotonic muscular dystrophy, and I have known that I had it since 1976. I did not get my diagnosis because I had symptoms or anything. I got my diagnosis because my father was diagnosed with it. He had passed out and was taken to a hospital and having some tests done. And he spoke to his doctor about some symptoms that he had been having. So through that, we found out that he had it. He also had a sister that had muscular dystrophy. Now, back in 1976, we had no idea that, it was myotonic muscular dystrophy or any of that kind of stuff. And excuse me, there were no easy blood tests or anything like that. So we had other testing procedures back then. So after he was diagnosed with it, then the doctor suggested that my older brother, myself, and my one younger sister, that we all be tested for it. I had a younger sister as well, but she was too young and they didn't want to test her. So my brother, my sister, and I, all three were tested. I was pregnant with my first child at the time. And we were all diagnosed with muscular dystrophy. It
Cindy,
was,
this
yes.
is Mike with the MDF. I believe
Yes.
your video has been turned off. Would you mind turning your video back on?
Okay, let me see if I can do that. Let me see what I'm doing to start
Great
my
job. That's
video.
it. We can see you now. That looks
You
great.
can?
Go ahead.
You can see me?
Yes.
Oh, okay. I don't see anything. All right. Okay. So get back to where I was. I did not have any fear at that point in time because I was 21 years old. And I knew that and was told that this was a later onset type of muscular dystrophy. It was not, I don't know, it just didn't really concern me at that time. However, it did affect my sister very differently. So I think my thing that I want to get across is your mindset, keep a good mindset is really important, and not to give in to the fear. Don't stop, don't give up on your life or the things that you want to do because you've gotten this diagnosis that can sound so scary. And that's, kind of how my sister took it on. So it took a little while for her to get into a better mind frame about it and realize that, this wasn't a death sentence at that point in time or anything. There might not ever be for her. Do your research, as a lot of people have said, and that's what I did. I started doing research and trying to learn as much as I could about this disease. I had to educate doctors, as almost all of them have said. Dr. Schwab has talked about, that you may have to do that with your own doctors. I did. I would take copies of stuff to my cardiologist because he would tell me that my muscular dystrophy didn't really have anything to do with the electrical components of my heart because it was just a muscle disease. Well, myotonic dystrophy is not just a muscle disease, as we all know. And so I was having the electrical issues with my heart because of my muscular dystrophy. It took a lot of me trying to educate doctors in that respect. And the keeping up with the cardiologist and the pulmonologist and the neurologist and all that came down on me real hard one time. And I was just like trying to keep all these appointments and get everything together. And I was seeing Dr. Playtez at Methodist Neurology, and she told me about the MD clinic that they were starting. And so I have been going there since the very beginning. And the fact that there was one place that I could go to that had all of these doctors and had the social workers and the physical therapist and the nutritionist and other people that could help me with scooters or whatever type thing that I needed was a huge godsend. A lot has happened in the medical community, I think, to help make this easier. I know my chart at Methodist is wonderful because it keeps all of my doctors connected. I'm lucky in the fact that all of my doctors are part of the Methodist system, so they are all on this, and so they can access all of my information at one time, and that's huge. But until that happened, it was my PCP that kept track of it all. So just remember that and have a good rapport with your PCP and don't be afraid to tell the doctor what's going on with you, or don't think that maybe it's insignificant. If you're having a symptom of some kind, don't just play it off. Be sure and tell them what's happening. There are a lot of things out there. We have to learn to do things in a different way. And there may become a point at some time when we absolutely can't do something that we were used to doing. But most of it is learning how to do it differently. If I have to have lever handles installed all throughout my house, if I have to have the little tool that gets up under the pull tab on cans, of soup or drinks or whatever to open it up with, and then I get that. There's a wrench that fits the top of a water bottle. So it makes a lever on the top of the water bottle that you can use to open it. Because we can do pretty much anything if it's got a lever on it, when we have muscular dystrophy. So there's a lot out there. And I have had a hard time dealing with just saying that I was disabled, or getting a disability placard so that I could park closer. Or when I needed to get a scooter to help me, not that I couldn't walk anymore, but that a lot of walking tired me out, that I no longer went to my Astros baseball games, which I loved to do because I couldn't walk from the parking lot and then all around the Minute Maid or the Dome at that time and stuff. Until I finally, got it through my head, it's okay for me to get this scooter and ride on it and give my body the rest that it needs to be able to do what I want to do. So go easy on yourself, be kind to yourself, and just rest when you need to. Get your good nutrition. That's so important. And one thing before I close, if I can throw in there, car manufacturers, when I got my scooter, I got one that would break down into 4 pieces so that it could be loaded into the trunk of my car. And, when I got somewhere, I could get the pieces out and put it together. Well, that only worked for a little while because the battery part of it is pretty heavy. And so it got to where I went from being able to go by myself to where my husband had to be with me again because he had to put the scooter together. And when we went to look at a new vehicle one time, my husband just happened to notice on reading some information that automobile manufacturers, 99% of them will give you money to do modifications that you need to do to your car. It may be $1,000, it may be $1,500. And to have a lift put into the back of my SUV so that I no longer had to break my scooter apart, and pick it up, put it in there for me, and I no longer had to have anybody go with me. anywhere I wanted to go. So there are things out there, and that's what community is about. The things that you don't know about on your own, somebody else does. So stay in touch with people. Don't be afraid to talk to people about it. And just don't be worried about what the world's thinking. You know, take care of yourself, love yourself, be kind to each other, and God bless. Thanks for having me.
Cindy, thank you so much. And
Sure.
Regan and Rebecca and Dr. Schroff. I'd like to ask all of our presenters to please unmute themselves and share their videos, and we'll have a moment for just one or two questions. Our first question for our panel, we have a lot of parents joining us today, and they have a lot of questions about communicating with a child. We're speaking especially about communicating with children when the adult has myotonic dystrophy and the child does not, or is not diagnosed with myotonic dystrophy, and communicating with them about what's going on with mom or dad, for example. I wonder if I could kick this first to Rebecca and get your insights about, how do parents, what are some tips for parents to communicate about myotonic dystrophy with children?
Thank you, Mike. And it is a great question. And I'm just going to give some general tips because regardless of what you're explaining to the younger child, what you want to do is keep it simple. You want to be appropriate for their age level. So if they're 14, you're going to address things a little differently than if they're 7 or 8. But there are a lot of resources in the community, books that have specifically been written about maybe not myotonic dystrophy, but just about different things. In fact, we should get somebody involved in writing a children's book about that. But many of the children's hospitals may already have access to those kinds of books. There's a great group in Texas called Wonders and Worries. And if you want to just Google that, Wonders and Worries, it may be available online, but it talks about their child life educators, and they talk about how to talk to children about different kinds of diseases. And I think that would be a great way to start.
Thank you, Rebecca. Cindy, I wonder if you have some thoughts on that, about communicating about myotonic dystrophy to children or folks of different age groups.
Okay. My children have known basically the whole time that they were growing up that I had it, but they have not. I didn't have any major symptoms during their young life, so it wasn't anything that they were real concerned about or that I was needed to broach with them. But it did become an issue as they got older and started thinking about their own families and whether or not they wanted to have children and stuff like that. So, you just be as honest with them as you can. And like Rebecca said, age appropriately honesty. And you look for whatever books and resources that are out there. But I think the main thing is just that they see you and they see how you are doing and how you handle it and what you put forth, no matter what stage of the MD that you have, is going to say a whole lot to them. Even more than your words are going to say sometimes.
Mike, can I just put in 2 more comments that I thought of as I was listening to Cindy? One would be that many times children asking about what's going on with you may be an indirect way of saying, are you going to die? Is something going to happen to you? Are you still going to be here? So I think for parents to reassure their child also to kind of address that question and the concern that you are getting good health care, you have a great team, and you're doing all the things that you need to be doing. And second of all, I think it's also, as we talked about, age appropriate, that as they get older, they're going to start Googling. So if you have questions, I may not know the answer, but text them to me, write them down. I'll find out from the docs, or give them good websites from the time they get old enough to start looking at that. So they're really getting accurate information.
That's good, Rebecca. I like that.
Thanks.
Dr. Schroff or Regan, do either of you have thoughts on speaking with children about myotonic dystrophy?
So I think, I mean, I agree with, Rebecca, it has to be age appropriate, like young kids with, talking to them, it's definitely different. You don't want them to stress and develop anxiety and get scared, that's the thing. But at the same time, they got to be aware, like if there are some symptoms, like if they're tired or too sleepy, it's okay. That's the part of the disease process, and not to kind of fight, but like fight with it or get upset or frustrated about it, but rather like have some like strategies where they don't get like anxious, frustrated about those symptoms, just to be aware of those symptoms. It can happen and it's a part of it. Yeah.
I would just add too, I mean, the visual portions, I think kids are good learners. Being visual, explaining to them in a visual aspect might help a little bit more. And I know there's some support groups, I'm sure, out there for children of parents with myotonic, and if not, we need to get that going, I'm sure. We don't see as many children because we are in an all-adult hospital. Rebecca said they used to be able to come into clinic, but that's one thing we don't have as much direct contact with, but I'm sure some of the pediatric hospitals and stuff like that may have better advice on educating children towards this disease process.
That's very helpful. Thank you, Regan. Another set of questions we've gotten, and we only have a few minutes left, but folks were wondering if our panel could talk about communicating with family members about the future, thinking about the future, and expectations. Rebecca and Regan both touched on this in their presentations, I think, and as did Cindy a little. But I wonder if you could expand on that a little. And again, I'd like to start with Rebecca.
I use a silly analogy. I call it silly, but it's really effective. I say that oftentimes we're in A, B, and C of our alphabet. We all have an alphabet of our lives, and everyone goes to X, Y, and Z. If we didn't do there, we wouldn't have wills or power of attorneys. But once we go to X, Y, and Z and gets those things taken care of, I think it's important to come back and live in our alphabet, because if not, we're spending all our moments worrying about tomorrow. So I think it's good to have the communication, but it's also, as Dr. Schroff was mentioning, be realistic about the symptoms and let them know that these symptoms don't necessarily mean that things are happening too quick. But at the same time, preparations and being realistic about there may come a time when I do have to make choices about that. And these are the things that I want you to know about that, and communicate it to all the families, so you don't have one son that thinks this and another son that thinks that everybody is on the same page.
Cindy, did you want to talk a little bit about that, about how to talk about the future with your family?
Okay. The future is going to be the future. I'm very, I don't worry about that. And I understand that children can do that. And I have a daughter that has muscular dystrophy, and I have a granddaughter who's 15. And so she is wondering, does she have it, and how it's going to affect her on down the line. And so it is, for the most part, I have to let her mother talk to her about that, because she's her mother. Now, if her mother comes to me and says, okay, well, Rebecca wants to know something, and can you talk to this with her about it and let her know what you think? I keep everything as upbeat as possible mostly because I'm just an upbeat person and I don't see any reason in dwelling, down in the mire of it. But I do let her know that there are some things that are more difficult for me to do and for her mother to do because she sees that. But that it's okay. We learned how to work with it and we learn how we can go through our life daily and have a good daily life and that's just part of it, that everybody has something that they deal with, in some way or another. And so it's just about learning how to do so. And, my faith plays a huge part in that. And, I hope that it does for her as well,
Cindy, thank you so much. We
Sure.
unfortunately have to leave this extraordinary panel now, and I was wondering if anyone has any final thoughts they'd like to share about communicating about DM to your family, to your doctors, and others in your lives.
I'll just say before I go, don't be afraid to tell a doctor. Don't be afraid to say, no, you're wrong about that. This is my disease. This is what I have. This is how it works. This is what happens. I know this because I live with it, because I've researched it. And, I know that this is not necessarily your expertise because no doctor is going to know about the hundreds of muscular dystrophies out there, and know each one and know how they affect people. So it's okay for you to let them know that and I think that's hard for a lot of people to do, that they'll just, let a doctor tell them, okay, this, and this. And even if in the back of your mind you're going, well, no, I don't think that's right, but sometimes we don't say anything. But don't be afraid to, know your disease. Education is important for you with your disease.
Cindy, I think that's the perfect place to wrap up. Thanks to our extraordinary panel, our live attendees. I encourage you to go to the concert in a few minutes, a special concert, and then join us for facilitated networking later today. There were a lot of questions today about insurance. There is a Stump the Expert with a health insurance panel tomorrow at the conference, so I hope you can join us for that. Panel, thank you all so much, and have a wonderful day.
Thank you. Thank you, Mike.
Bye.
Thank you.
Bye-bye.
Bye-bye.